Should dysphagia patients get crushed medications? The pros and cons of crushed medicine. Crush patients' meds with applesauce? How many times have you written that as a recommendation? Or what about this? Can you come see this patient? They're having trouble swallowing their pills. If you're an SLP, you may have heard this about 1,000,000 times. Trouble swallowing pills is a common complaint from our patients with dysphagia. While we may have the best intentions by recommending something to make pills go down easier, we can actually create more harm than good. As SLPs, it's really important to understand the ins and outs of different medication delivery modes. That's why today we're going to be talking about the pros and cons of crushing medications. And answering the question, should dysphagia patients get crushed medications? Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. The pros. Why would a patient benefit from crushing or altering their meds? From an SLP perspective, the main pro for crushing medications is that for some patients, it can be much safer and more efficient to swallow crushed pills in puree versus whole pills with liquid. But this isn't the case for everyone. Later in this video, we'll also talk about some other options for patients who cannot comfortably or safely swallow whole pills, but who might not need to crush them either. Why might some patients need their pills crushed? Some patients do not have the lingual coordination or adequate airway protection to take whole pills safely and/or efficiently, making whole pills dangerous and ineffective for them. No one benefits from having a pill in their trachea after all. Some patients might be prescribed medication, but choose not to take it because they feel they can't swallow it safely or comfortably. Some patients have upper esophageal issues such as strictures or webs that are problematic when it comes to pills. We can work alongside GI or ENT to recommend safe ways to take oral medications in these cases. So how do you know if your patient is having trouble with pills, to the point where your patient may benefit from altering the way they take medications? Imaging, of course. We cannot assume there needs to be an alteration of medication delivery without viewing it on an instrumental. We cannot treat or compensate for what we cannot see. Consult with your radiology team regarding possible different modes of assessing pill delivery, such as barium tablets, barium-filled capsules, etc., for video swallow studies. You might trial barium tablets or capsules with various consistencies or gels under fluoro for further assessment of bolus flow. Fees may provide further flexibility in evaluation to utilize the patient's actual medication, or you can substitute small M&Ms or vitamins, etc., to mimic real-life scenarios in delivery. There's also this helpful patient-reported outcome measure, or PROM, called the PIL-5 Screening Questionnaire. We'll link that below. This questionnaire looks at how frequently your patient experiences things like pills sticking in their throat, pills stuck in the chest, the fear of swallowing pills, if their problem swallowing pills interferes with their ability to take their medicine, and whether or not they take their pills without crushing, coating, or using other forms of assistance. It is absolutely important that you refer to the Do Not Crush list of medications and speak regularly with your patient's nurses and medical staff about crushing meds before instructing your patient to chew their pills. We'll dive more into this later. One of the most common cases I've seen where crushing meds or switching to liquid form was necessary involve cases where the UES either did not completely relax or did not relax long enough to allow solids to pass. Whether it was because of a brainstem stroke, radiation treatment, or chronic severe acid reflux, I've seen many pills simply not pass through the UES in these cases. However, purees and liquids were fine or improved with compensatory strategies. These cases could be temporary or permanent depending on the patient's medical history. Early on in my career, I used to think that crushing meds was fine to recommend for any patient who demonstrated difficulty with swallowing pills. But as I'm about to discuss in my second point, crushing all meds can't always be an option. Now that you know more about the reasons why you might recommend crushing meds or not, or why it's so important to examine symptoms of pill dysphagia with video fluoroscopy and fees, and the potential risks and dangers of recommending crushed meds unnecessarily, let's talk about a few resources to use if you do have a dysphagia patient who really would benefit from crushing their medications. And if you're finding this video helpful, please remember to hit the subscribe button so you don't miss out on future videos like this one. And if you know any other SLPs or aspiring SLPs who would benefit from learning more about this topic, please share it with them. The cons. Crushing meds can be risky, and what is bioavailability anyways? Although there are some cases where crushing meds can be beneficial, it's even more important to understand that recommending crushed meds, especially if it's not 100% necessary, can be problematic. Aside from crushed up pills having a very bitter taste and increasing the chances of patients not taking their full doses, we need to consider bioavailability. What is bioavailability? It is the proportion of a drug or other substance that's able to be absorbed and used by the body. So what can happen if medication delivery is modified? Altering medication delivery for patients with dysphagia may alter the bioavailability, the amount the body is able to absorb, or have iatrogenic, possibly harmful effects, depending on the medication. When we crush and mix meds, we affect bioavailability. For example, mixing some complex antibiotics with dairy, such as ice cream or milk, may prevent absorption and reduce the bioavailability. Cornstarch and gum-based thickeners are polymers, and they chemically and physically bind with crushed medication to cause a significant reduction in the way the medication is absorbed. Chewing or crushing extended-release medications can result in a dangerously rapid absorption of a large dose of medicine that was meant to be released very slowly over time. An example of this would be crushing a potent opioid like oxycodone, which is meant to be absorbed over 12 hours. If this drug is crushed and consumed, then it leads to the rapid absorption of this opioid and can result in sedation and respiratory depression, even death. An SLP friend of mine shared a major lesson that she learned about not crushing all meds and the dangers this could impose if we're not careful with which meds are being crushed. She was working with a patient with dysphagia and had him chew an extended-release blood pressure pill, only to find that the patient's blood pressure started to drop pretty rapidly and significantly within 10 minutes of chewing and swallowing the pill. She immediately called in the nurse, and the nurse instantly went to work on reversing the effects of the medication to stabilize the patient's blood pressure. Just hearing this story has stuck with me and served as a good reminder to always check with the medical team and pharmacy before directing patients to chew or crush their pills. What can you do if you think your patient needs their meds crushed? Collaborate with your pharmacists and primary care physicians. Collaborating with the primary care physicians and pharmacists to create an interdisciplinary approach is recommended to provide the patient with the appropriate medical care within their dysphagia recommendations. The pharmacy may be able to offer suggestions regarding substitutions for medications that cannot be crushed, such as immediate release, compound, powder, mixable substance, the tablets cut in half, IV delivery, etc. There is a risk of an inefficient and ineffective communication system, which possibly results in inappropriate medication administration to a significant number of patients with dysphagia. Incorporating pharmacy computer systems, educational campaigns, and ensuring communication between SLPs, nursing, and pharmacists may aid in preventing the crushing of extended-release medication, per Jackson et al. In 2008. Some other options other than crushing include seeing if there is a liquid form of the medication or supplement, swallow them whole, embedded in a smooth substance like applesauce, yogurt, or ice cream, being mindful of dairy. Crush the medications and put them in a smooth substance to swallow all at once. An SLP inside of the MedSLP Collective shared her tricky experience as a home health SLP navigating pill dysphagia. She had a patient in her 60s who had a video fluoroscopy due to complaints of pill dysphagia. She was afraid to take pills if no one was there with her and felt as though the pills got stuck in her throat. Her diagnoses included stroke, diabetes, hypertension, chronic kidney disease, coronary artery disease, GERD, hernia, esophageal stenosis, and lumbar spinal stenosis. The patient also reported that she had her esophagus stretched several times in the past as well. The SLP suspected the pill issue was esophageal and referred the patient to get a video fluoroscopy. The video fluoroscopy revealed poor esophageal emptying with recommendations to see her GI doctor again and for meds to be crushed or in liquid form. This patient was on a lot of meds. Using a resource from the MedSLP Collective, she discovered that her patient had multiple pills that were on the do not crush list, mainly due to those pills being slow release. As a home health SLP, she felt a little stuck. It's easy to collaborate with pharmacy, physicians, and nurses when you're in the hospital. It's a different story in a patient's house. She ultimately contacted her patient's primary care physician to share the video fluoroscopy results and recommendations, and she was referred to GI, where they managed her esophageal motility and swapped out certain medications to liquid form. Teamwork makes the dream work. If you'd like to tune into a conversation dedicated to this very topic, check out episode 173 of the Swallow Your Pride podcast, where Amanda Weisberg dives into the considerations we need to keep in mind when recommending how our patients should take their medication. We also have a resource titled To Crush or Not to Crush, Crushing Medication Considerations inside the MedSLP Collective. If you're interested in becoming a member and absorbing our library of resources, webinars, journal club discussions, and more, head over to the link in the bio to join the MedSLP Collective today.